So good morning everybody. Now we are going to start our session. This is post-operative endophthalmitis, a case-based management. As you know, endophthalmitis is the most dreaded complications in any ocular surgery. So in this session, what we are going to do is, this will be a case-based presentation, where for presentation 4 minutes is assigned. After that, we will have discussions for 6 minutes. So now I invite Santosh Mahapatra, the convener, and our first speaker is Dr. Pratik Nishant. He will be presenting a case from cataract file.
Thank you, respected chairpersons, dear members of the audience. Good morning. I'm Dr. Pratik Nishant from All India Institute of Medical Sciences, Patna, and this is my presentation on post-operative endophthalmitis case reports from the Cataract Files 1. No financial disclosures and patient's consent has been taken for this presentation. To introduce, endophthalmitis, as we know, is a serious and vision-threatening complication encountered after intraocular surgery. Cluster infection is defined as the occurrence of more than or equal to 2 infections in a single day from one theater, or the occurrence of repeated postoperative infections. The incidence of post-cataract surgery infection worldwide, as per sub-reports, is 0.04 to 0.2%, and predisposing factors include uncontrolled diabetes, prolonged operative time, or complicated surgery, and of course, breach of sterility protocols. I am presenting a case series of 3 males and 1 female patient who presented with pain, redness, and watering associated with acute loss of vision in the operated eye after cataract surgery done at a single center 5 days ago. These are the case sheets or the files. The vision in the operated eye in 2 cases was no PL, and the third case and fourth case was PL positive with inaccurate projection of rays. In the contralateral eye also, the first and the second cases had poor vision, whereas the third and fourth case had moderate visual impairment. In the IOP in the affected and in the normal eye is as listed. In the anterior segment, we found lid edema, diffuse conjunctival congestion, corneal abscess, total hypopyon with pus coming out of a sclerocorneal tunnel in the first 2 cases. In the third case, we had striate keratopathy, 4+ cells, a hypopyon of 2.5 millimeter, and a fibrin membrane with poorly dilating pupil, and a conjunctival congestion and striate keratopathy with a similar picture in the fourth case as well. In the contralateral eye, the normal eye, all the findings were within normal limits. In the operated eye, the lens in the first case was not visualized, as was the case in the fourth case. And in the second and third cases, we could visualize the posterior chamber intraocular lens. And in the other eye, in the first case, the lens was clear, and the other 3 cases had immature senile cataract. With no view of the fundus, we did a B scan and found moderate vitreous echoes in all the 4 cases. In the fundus of the other eye, in case 1, showed proliferative diabetic retinopathy. Most importantly, systemic issues which were found with the 2 cases were uncontrolled diabetes mellitus and hypertension in case 1 and case 2. That said, we had a strong index of suspicion of whether it was TAS or endophthalmitis, and we went for this differentiation of whether the timing of the onset of symptoms and signs was within 12 or 24 hours, indicating it was TAS, or it was slightly delayed, indicating endophthalmitis. Whether there was pain or decrease in visual acuity, mild or moderate or severe. The IOP, as we just saw, was slightly increased or maybe normal in our cases. Corneal edema is supposed to be severe limbus to limbus in TAS, but not so in endophthalmitis. Fibrin hypopyon and vitritis is typically present in endophthalmitis and quite less or milder compared to endophthalmitis in TAS. And an association with diabetes is very likely in cases of endophthalmitis. We probed further and came to know that the primary surgery in these cases was, in the case 1, it was SICS plus PCL followed by IOL explantation the next day. In case 4, it was anterior chamber IOL implantation with explantation the next day, as there was a history of small incision cataract surgery with aphakia a month back. And in the second and third cases, there was SICS and PCIOL. So diagnosis in the first two cases was panophthalmitis, and in the case 3 and case 4 was endophthalmitis. Treatment was undertaken in the form of core vitrectomy, vitreous biopsy, intravitreal antibiotics like vancomycin, ceftazidime, and dexamethasone. IUL was explanted in the cases in which we found a posterior chamber IUL. And the vitreous biopsy from the four cases is as shown in the figure. In all cases, Acinetobacter baumannii, sensitive to amikacin, was cultured from the vitreous biopsy. Subsequently, the first two cases were not intervened, and case 3 and case 4 were intervened again. And this is the advice at discharge for all cases: moxifloxacin, amikacin hourly, carboxymethyl cellulose, and atropine eye drops, with steroids in the last two cases. So, two cases of endophthalmitis which underwent repeat intravitreal antibiotics, including amikacin, recovered to some extent, and the two cases of panophthalmitis were not intervened owing to explained nil visual prognosis and ended in phthisis bulbi. For the contralateral eyes, the contralateral eye of the first case underwent panretinal photocoagulation with glycemic control with explained guarded visual prognosis in view of proliferative diabetic retinopathy. And the contralateral eyes of the other cases were operated with phacoemulsification with PCIOL with good visual outcome. About Acinetobacter baumannii, it is a typically short, almost round, rod-shaped Coccobacillus gram-negative bacterium, and it is now being referred as an opportunistic infection, and it is highly prevalent in hospital settings, especially in immunocompromised patients like chronic lung disease or diabetes patients, or in illnesses that require use of a hospital ventilator or urinary catheters. A. baumannii can spread through direct contact with surfaces, objects, and the skin of contaminated persons. Our case series presents 4 cases of endophthalmitis caused by Acinetobacter, which itself is not a very common cause of endophthalmitis, and the occurrence of its species A. baumannii is even rarer. Parvaresh et al. Have reported a case of endophthalmitis by this organism as the first clinical presentation of diabetes mellitus, which was found sensitive to colistin. Bittergen et al. Have also reported one such case which had to undergo vitrectomy 10 days after cataract surgery, but somehow had good visual outcome.
Please wind up. Please wind.
From the East India, only one case series of 4 cases was reported in literature in 2009 to 2011 by Roy et al. In these series, all the organisms were sensitive to ciprofloxacin and resistant to ceftazidime. Based on their findings, they commented that ciprofloxacin should be considered as the first-line antibiotic in A. baumannii endophthalmitis. However, our isolates show a different pattern of antibiotic sensitivity. The occurrence of this atypical organism in our isolates implies that A. baumannii is an emerging culprit of postoperative cluster endophthalmitis in eastern India, whereas amikacin should now be considered a first-line drug in addition to ciprofloxacin. Amikacin 400 micrograms per 0.1 ml is considered highly retinotoxic, and the dose is revised to 125 micrograms per 0.1 ml, especially in vitrectomized eyes. However, in our cases, we went for a 400 microgram per 0.1 ml, looking at the fulminant picture, and definite evidence of retinotoxicity was not actually seen, which may be due to high infective load. 2 of our patients had uncontrolled diabetes and hypertension, hence the role of systemic control for the prevention of endophthalmitis and thorough pre-operative preparation cannot be overemphasized. As a take-home message, I'd like to convey that A. baumannii is a very rare cause of common source endophthalmitis, which needs close epidemiologic monitoring, and it has poor visual and anatomical outcomes, hence prevention and high index of suspicion are the key. Management of endophthalmitis includes immediate intravitreal antibiotics, timely referral to higher center for vitreoretinal intervention, and amikacin should now be considered as the first line in sensitive A. baumannii isolates, although this might change on a case-to-case basis. Thank you.
Next is yours.
Thank you, Nishant. That was a very good series. But one question I have, like, all those 4 cases were diabetic? No, only 2 were diabetic.
Only 2 were diabetic.
But all 4 had the same organism.
Exactly,
so
sir.
do you implicate that it's because of the uncontrolled diabetes, or there could have been certain external factors?
Diabetes alone cannot be implicated in these cases, as it is a common source endophthalmitis, basically. So, not post-operative endophthalmitis can have many etiological lines from which it emerges. Like some people might have a poor glycemic control. Some people might suffer trauma after surgery, or some people might just have the unfortunate event of being operated in an OT in which such organism is present. We could not, in fact, trace the operating hospital or the operating, operating surgeon, or maybe the operating team, or
Okay.
even the viscoelastics or the BSS. Nothing could be traced.
In your
In
case
this
series,
case.
what can be the cause you suspect?
Pardon, sir?
In your case series, what can be the cause?
We thought this is due to something related to the operating environment itself. This is not related to patient factors.
And all of them presented on which day?
Fifth day of the
Fifth
surgery.
day. Okay.
Fifth day of the surgery.
Thank you.
Okay, thank you.
So in all the cases, what was the initial presenting symptom and sign? Was there any common symptom and sign
So,
initial
so we did
that
list.
gave a suspicion that
So
these
we did
cases
list
are?
common symptoms in these patients, like pain, redness, watering, and loss of vision. In all these patients, and the common signs were in the first two cases which presented with no PL. It was corneal abscess and a total hypopyon with pus coming out of the sclerocorneal tunnel, and in the rest two cases it was a fibrin membrane and a dense hypopyon and intense inflammation in the anterior chamber.
I mean, most of the cases of endophthalmitis, I mean, the most commonest symptom is decreased vision, followed by pain and other things. So this is one point which has to be noted, because pain is not present in almost all cases. It's only present in around 70% of the cases.
Exactly.
But-
We are looking for RSVP, right?
And second sign, that presence of hypopyon also is a very strong indicative factor that this is a case of endophthalmitis.
Yes.
Yeah. Speakers, please
Doctor.
limit your time to your 5 minutes. We won't have time to discuss your cases otherwise. Thank you.
So thank you, Pratik. And next, can you introduce Dr. Ajit Dwivedi? He's from Patna. He's primarily a glaucoma person.
Next, मेरा था actually. Okay, Dr. Ajit Dwivedi is a very dynamic glaucoma surgeon from Patna, and he has special interest in glaucoma valve implants. And currently, he is the editor of the Patna Ophthalmic Society Journal. So, Dr. Ajit will present.
So, very good morning, and thank you, Dr. Deepak and Dr. Pranav sir and the whole of the AIOC scientific committee for making me here. And my topic is endophthalmitis following glaucoma filtering surgery. So there is nil financial interest, and we all know that trabeculotomy is the most commonly performed glaucoma surgery. It's performed at intent of functional bleb without medication, achieving lifelong target IOP. But complications and success challenges post-trap surgery make it most exciting and sometimes even dreadful among ophthalmologists to perform. So, as we know that the glaucoma surgery started in 1856, and we have changes. We have seen the glaucoma filtration surgery coming in 60s, and still you can say it remains the gold standard surgical procedure for achieving target IOP in glaucoma patients. During this procedure, a fistula is created between the anterior chamber and the subtenon space in order to allow the aqueous humor to bypass the trabecular meshwork. So it's not without complication, and it's the early and late complication has made it very much dreadful to perform, and many a times the patients are getting late. So we are discussing about the infections which is bleb related, right from the early to the late, how we can manage. So there are two presentations. One is it's classified on the basis of blebitis and bleb-related endophthalmitis, which is more common than the blebitis. And this bleb-related infections can present in early periods, less than 1 month, or it can be after 1 month, which is more common. So epidemiology, since we have seen, has changed. If we go to the endophthalmitis in any ophthalmic surgery, it's hardly 0.093%. And in TRAB, before the augmented procedures have come like a few mmC, it was 1.5%. And later on, when it has come in the initial phases, so it has almost 13% incidence. But with the advent of refinement of the surgical technique has reduced in incidence with the application of MMC over a wider area in a conjunctiva, not on a single point. And at the same time, there was a modification like releasable sutures, tight anchor sutures. There are different variables as well that lead to the uh, reduced incidence. And at the same time, the approach, which was earlier used to be a limbal based, it has changed to the fornix based mode in that one, and fornix based has a lesser infections as well, and abandoning the inferiorly placed trabeculectomy, which was done in the initial phases. So, clinical presentations in bleb-related infections are stage 1, which is called blebitis, and there is a stage 2. We will come with the cases just after this. This is a blebitis with anterior chamber reactions, and then it comes stage 3, which is called bleb-related endophthalmitis, again further subdivided into mild vitreous involvement in a stage 3A, and there is a marked vitreous involvement in a stage 3B. It's very important to understand. If you see this stage 1 blebitis patients, there is a redness, congestion in that area. Unless we will invert the lead, we will unable to see that one. And at the same time, there is a marked milky white appearance of the bleb with loss of clarity in that area. And in the stage 2, the infiltration has raised, and the anterior segment is also involved in a form of infiltrate. There are some reactions as well. And even at this stage, there is need of instant intensive treatment, so that we cannot progress to the stage 3, which is here you can see a stage 32-year-old man presented with severe pain and sudden decrease in vision for one day in his left eye 3 years after trabeculectomy. And you can see here the hypopian, there is much of AC reactions along with the infiltrate in the bleb area. It was well managed, we will discuss later. And coming to the risk factors, bleb localization was the most important factor, which was already changed inferiorly. The inferior traps had been abandoned. Then the conjunctival approach, we have discussed fornix based and leaking bleb. At the same time, if we have antimetabolites, which is nowadays a normal procedure, endophthalmitis rates are little bit higher because the blebs are thin and cystic. But surprisingly, combined surgery has a lesser bleb-related endophthalmitis reported. And if there is a history of previous infections, it is mode and presence of conjunctivitis and blepharitis always increases the bleb-related endophthalmitis. Our clinical diagnosis and workup must include ultrasonography to rule out vitreous involvement in stage 2 and 3, and microbiological
Can you
workup.
sum up?
Yes. Just microbiological workup should include conjunctival swab over bleb. Apart from this fungal endophthalmitis is very rare in bleb-related infections, and our management is instant intensive treatment where they detect the disease early with the patient sensitization and distinguish the disease stage early by the clinicians and identify the organism if possible. So, in stage 1 and 2, we can use topical fluorochlorins or fortified cefazolin, subconjunctival or intraocular injections of antibiotics, and systemic antibiotic therapy is recommended here, especially oral fluoxetine, which can have a good penetration inside the tissue. Vitrectomy in late stage and stage 2, 3 cases are required, and hospitalization will require in stage 2 and 3. Steroids, not to start topical steroids until the infection appears to be controlled, and usually 24 to 48 hours after antibiotic use. Endophthalmitic EVS study recommendations are not applied to the bleb-related endophthalmitis, and early treatment and immediate PPV has a better result than only IV antibiotics. So there are challenges, and we can say it's regarding the function of the filtration bleb. That's why post-op glaucoma evaluation is essential. That may require additional medication and glaucoma drainage devices for new target IOP. Coming to the case, this case was presented with a hypopian in the early phase and with the bleb infiltrate, And after proper vitrectomy and uh, systemic antibiotics, this was well managed and quiescent now, but there was a thin cystic bleb in that area, and that was detected during post-op glaucoma evaluation. The conjunctival autograft was done after 1 month, and after healing of this graft, 2 months later, we have a very good diffuse bleb. But this is not a case always, so we may need in a rehabilitation is also important in those cases where if we have an anterior staphyloma, we can give prosthetic contact lens to increase the good view along with the phthisis, pre-phthysical eye. And if we have lost the eye, we can provide the customized ocular prosthesis too. So to summarize with, blebitis can be treated with instant intensive treatment. Bleb-related endophthalmitis usually present as late onset endophthalmitis. Patient sensitization is must. EVS recommendations are not applicable in BRIs and should be treated promptly even with systemic antibiotics. And bleb salvage surgery and new target IOP after infection control should be done. Rehabilitation can do wonders with low vision aids and cosmesis. So sensitization to trap vision, we can say to our patient that any redness and congestion in the bleb area or in an eye should be taken seriously and reported to the ophthalmologist very early. And even with the clinician, early detection and high suspicion is required. Prompt execution and management can provide good results. Post-op glaucoma evaluation is must, where we can do wonders like in one case, and rehabilitation can boost the patient life. Thank you for the patient listening.
Sorry for the interruption. If speakers exceed their time by 4 or 5 minutes, other speakers won't get their time to talk. We'll have to hand over the hall to the next session.
So the next speakers will take 5 minutes of speaking time and 5 minutes of discussion so that we can complete in time. Just one brief question. Does the incidence of endophthalmitis increases by use of mitomycin C?
Definitely, it has increased earlier. Later on, with the modified Morfield shape surgical system, it has decreased. But more than that, the normal intraocular surgeries, because there is a transconjunctival migrations in a thin cystic area. But risk is there, but we cannot say that it should not be used.
So, okay, right, we'll discuss it after this case. This is a very interesting topic, endophthalmitis, bleb related. The next speaker we have is Dr. Deepak Agrawal. He is a prolific vitreoretina surgeon from Patna. Presently, he is also the treasurer of the Bihar State Vitreoretinal Society, and he is going to take up the next case, cataract files from Cataract.
Thank you, sir. Good morning, everyone. I thank Pranav Ranjan sir and AIOS for giving me this opportunity to be here. So case one, this is a patient who was referred 3 days post-cataract surgery with a vision of hand movements. And for him, we did an early vitrectomy, and the post-op vision after vitrectomy was 6/12. So as you can see here, this patient, there is a tenacious fibrinous exudate inside the anterior chamber, and this was teased out using the Sinskey hook. And then core vitrectomy and vitrectomy till, depending upon the visibility, was completed. And finally, a good red glow could be achieved. And intravitreal antibiotics, vancomycin, ceftazidime, and dexamethasone was given. So the reason I'm showing this is because it's an acute bacterial endophthalmitis, and by doing an early vitrectomy here, the post-operative visual outcomes are very good. So you can see a very good glow here. So the second case is of a patient who was referred 4 weeks after cataract surgery with defective vision. Vision was hand movements, and his case record showed episodes of recurrent inflammation in the post-operative period, which subsided with topical steroids. So here, a AC wash with vitrectomy with a capsulectomy was done. However, being a chronic endophthalmitis, IOL removal was advised, but the patient denied it. So in the first go, we did not do the IOL removal. So as you can see here, there is a focal area of abscess or exudate behind the IOL, and this is very typical of a fungal endophthalmitis. So the anterior chamber was cleared of the exudate, and then we had gone inside. And ideally for fungal cases, it is actually it is good to do an IOL explantation and silicone oil injection in the first stage itself, because if we leave any exudates inside the vitreous, there will be a recurrence. So a complete vitrectomy by indenting the vitreous base should be done to remove whatever vitreous is there. So however, this patient again developed a reaction and exudates. So after a month again he had developed, and so we did an IOL removal with silicone oil injection. So this was the case here, and now we are doing an IOL removal. And in the third stage, a silicone oil removal was done. And after that, a scleral fixation IOL was done after 3 months of SOR. So finally, the visual outcome was 6/12 in this patient. So another case here, which was referred 7 days after post-cataract surgery. The reason I'm showing this case here is because of the poor wound architecture. And if there is a poor wound architecture, a poor tunnel effect in the SICS tunnel, the risk of endophthalmitis will be quite high. So you can see here, the section here is quite jagged, ragged here, and irregular. And this must have been the cause of the endophthalmitis. So it was quite a fulminant endophthalmitis, and finally this eye had gone into phthisis. It was just a bag of pus. Another similar case here, a poor wound architecture with corneal involvement. The whole cornea was involved, and the whole vitreous was filled with exudate. So again, the IOL here was removed, and the section was sutured properly. So basically, to conclude, technological advancements in vitreoretinal surgery since EVS have minimized the risks associated with vitrectomy, and therefore it can be done initially even in less severe cases. Therefore, perform early and complete vitrectomy. So as Celsus had stated 2 millenniums ago, UB pus AB evacua, which means if there is pus, it needs to be evacuated. So his words can't be truer today. Thank you.
Thank you, Dr. Deepak. I think your message regarding early and complete vitrectomy is the key, but at the same time you need to diagnose the cases at early. So I'll show in my presentation that you can save the IOL sometime, most of the times, if you have the case is detected early. Otherwise, in fungal endophthalmitis, as you said, complete vitrectomy is the rule.
So, and one message regarding endophthalmitis and cataract surgery is that wound leakage is one of the primary factors which is responsible for endophthalmitis. And secondly, the incidence of endophthalmitis with clear corneal incision has gone up probably.
Gone up.
Yeah. So this is
in
one
my
thing.
experience also, I have found that most of the cases which have a poor wound architecture or a wound leak do develop endophthalmitis, and therefore if there is any doubt regarding the integrity of the wound, there is no harm in putting one suture for that, because that is going to be very helpful in the long run.
And then one small question, the role of intracameral moxifloxacin, does it reduce the
Yes, studies, even the Arvind study, which has been published, definitely has shown that the use of intracameral moxifloxacin has an advantage if we in the incidence of endophthalmitis. If it is not used, definitely the incidence was higher in those cases. Yes.
Do you recommend in all cases of cataract?
Yes, I do recommend. Yes. Ultimately, it gives a peace of mind also, and I don't find any reaction. I mean, I've been using it for over so many years, and there is no evidence of any TAS also associated with it.
I also agree with Dr. Deepak Agarwal. I have been using moxifloxacin for the last almost 14 years in all cases.
Yes.
In all cases.
And one should not sigh of putting a suture rather than.
Pardon?
One should not sigh to put a suture.
Yeah, one should not be
Absolutely.
shy in putting a
Yeah.
suture.
The
Absolutely.
wound has to be absolutely tight.
Tight. Yes.
Thank you.
Thank you.
Next,
Next.
we have.
Next, can I invite Dr. Rakhi, who is additional professor at IGIMS, and she is actually the golden girl of Bihar. I would say she has won the best paper for cornea in AIOS, and she's a dynamic cornea surgeon. So, Dr. Rakhi.
Thank you so much for kind introduction. First of all, I would like to thank Pranav sir and AIO Scientific Committee for giving me this opportunity. So I'll be presenting a case of post-keratoplasty endophthalmitis. So this is a case of 61-year-old man who referred to us for second opinion. He presented to us with redness, pain and diminution of vision for 4 days, and he had a history of triple procedure which was done 9 days ago. So on this, this is the timeline of the patient. On the discharge summary, it was written that patient on the time of discharge, he had graph clarity 4+, and visual acuity was 660, and at that time AC was formed and coiled. On day 5, he developed redness and pain, but he had taken no consultation at that time. On day 7, he consulted at the same center where he was operated, and at the time of visit, he had white infiltrate. It was mentioned on the card that it was a white infiltrate near in the superior temporal quadrant. The size was not there, and it was not written that epithelial defect was there or not. Hypopyon, streak hypopyon was mentioned, and B scan showed echoes in vitreous, and patient was planned for intravitreal antibiotics, and topical treatment was started. But no intravitreal antibiotics were given at that time. So he was referred to us on day 9, and at that time on examination, we found that there was graft edema of present, and graft clarity was 2 to 3+. The AC was filled with the hypopyon. It was up to around 5 to 6 millimeter. Corneal sensation was normal, and there was involvement of graft host junction in the superior temporal as well as in the inferior nasal quadrant of about 1 to 2 millimeter. Still epithelial defect was not there. So we planned for pars plana vitrectomy because cornea was clear at that time, and along with intravitreal injection. So retina consultation was done, and patient was posted for intravitreal antibiotics with PPV. It was done, and sample, the AC tap and vitreous tap was sent for microbiological investigation, and we started the routine empirical therapy including vancomycin and ceftazidime along with cycloplegics. Steroids were stopped at that time. And after 48 hours, we got the report of culture which showed methicillin resistant Coagulase negative Staphylococcus, and that was sensitive to vancomycin, gentamicin, amikacin, and linezolid. So we continued the same therapy, and patient improvement was there. And after a month in follow-up, we saw that endophthalmitis was completely resolved, but the graph clarity came down to 2+, and there was a sign of graph failure. So in this case, 2 or 3 problematic points were there. Patient presented very late, 4 days late after onset of symptoms, And after appearance of this endophthalmitis, we could not trace the donor rim, and we could not get the culture of residual donor rim and the media. And because of the delayed presentation, we could start the management late. So there are some peculiarities of endophthalmitis following keratoplasty which make it different from the post-cataract endophthalmitis in terms of rate of incidence, risk factors, the microbial spectra, clinical picture, and management. So as far as incidence is concerned, its incidence is 0.08 to 0.77, which is showing some downtrend. And initially it was thought that rate of endophthalmitis after PK was more than endothelial keratoplasty, but nowadays there are literature showing that rate of endophthalmitis after EK is more than PK because of some additional step of donor corneal preparation, sometimes in eye bank and sometimes in OT with the prolonged time, and additional intraoperative manipulation. And also it gives a dead space for organism to grow. So what are the risk factors other than post-cataract endophthalmitis cases? There are additional risk factor of donor tissue contamination. If we retrieve a donor tissue from a patient dying from any kind of infective disorder or he has a septicemia at the time of death, or if has a history of prolonged ICU stay, in these cases donor tissue contamination are very common. So we need to have a good sepsis at the time of retrieval and processing and during surgery. There are host factors also like high risk indication in cases of microbial keratitis, in cases of wound dehiscence, corneal perforation. These are the cases which are at risk of developing endophthalmitis in post-operative phase. And other than that, the post-operative events like suture removal, wound dehiscence, vitreous and calcination, they make the patients at risk for endophthalmitis. In etiology, it's similar to the post-cataract endophthalmitis, but here because donor to host transmissions are common, so gram-negative bacilli are very commonly found in these cases, and especially MDR. So unlike cataract, post-cataract endophthalmitis, here we get high culture positivity in post-keratoplasty patient, and with higher bacterial load, the organisms are probably of great virulence, and donor cornea is as a source of infection, and these patients uses steroid for a longer time. So this is a study from LVPI. They studied 28 eyes in 13 years, and they found that gram-negative bacilli are more prevalent in these cases, in contrary to the data from the Western countries that have quoted fungal organisms are more common. So as far as clinical picture is present, these patients can present within 6 weeks or more than 6 weeks. Both will have similar picture, graft edema, severe AC reaction, hypopyon, and loss of red glow. But here the important point is always try to differentiate acute graft rejection from endophthalmitis, because both of these entities will present same at the time of presentation. So it's very important to look the vitreous exudate on B scan and segregate these two entities, because they both have completely different management. In management and prevention, unlike post-cataract endophthalmitis, these patients, we have limited evidence to guide the initial management, and because of dense corneal edema and associated keratitis and corneal involvement, the view may be limited for any intravitreal procedures. And after even the best of efforts, we can have the graft failure in these cases. So overall management is same like keratitis, corneal scraping or intravitreal injection, endophthalmectomy, or if possible removal of graft or IOL. So the preventive measurements are more important. At the time of retrieval, we should screen the donor properly for any evidence of infection. We should instill the povidone iodine for at least 3 minutes, and if possible, more potent antibiotics or antifungal should be incorporated into the corneal preservation media. So outcome after the best effort, these patients usually may resolve after certain period of time, but the graft actually it gets failed, and patient's visual outcome is very poor. Anatomical restoration can be done with best efforts, but visual outcomes remains poor, and so these patients may require regrafting after certain period of time. So, post-keratoplasty endophthalmitis is a rare complication associated with devastating visual loss and poor structural outcomes. So, these patients always require a good follow-up for timely detection and management of endophthalmitis or any other event which is related to keratoplasty. Thank you so much.
Thank you, Dr. Rakhi. Just one question. Like, do you think the management, if it is a donor-related endophthalmitis and an acute endophthalmitis, is the management going to be different? And which is more common? Is it the
there are studies like if you take the lamellar keratoplasty, you will find more common is donor-related infection, donor to host transmission. But in cases of PK where we apply number of sutures and patient may get wound dehiscence, trauma, epithelial defect, poor ocular surface, in these cases, endophthalmitis, non-donor related is common. So in cases of donor to host transmission, we should always get to know that what is the organism present in the rim culture, so that we can get the sensitivity fast and we can work according to the reports. Because as the literature shows and as we have seen in our scenario, that gram-negative bacilli are very common in donor to host, particularly Pseudomonas klebsiella, and they are very resistant to routine therapies. They are sensitive to colistin or imipenem. So we have to start these therapy in early stages to restore the integrity as well as the visual outcomes.
Thank you.
Yeah, very nice presentation, Dr. Raki. One thing, I just wanted to ask you how to differentiate between a graft rejection and endophthalmitis. Should we do a ultrasonography? Because if there is a graft rejection or endophthalmitis, how to differentiate between a graft rejection and endophthalmitis? So for that, should we do a ultrasonography in all cases? Because the corneal haze and edema in both the cases are going to give us difficulty in visualizing the vitreous and the retina.
In donor to host transmission, you want to ask?
Yeah.
In these cases, usually infection starts from the graft host junction. And in normal cases, you can have hypopion or the decrease in the glow or decrease in the vision. But in these cases, donor to host transmission, there is multiple foci of infiltrates at the host graft host junction. And these are the clue that you can go for the culture and everything of the rim and media. That what was the organism and how to trace it and how to deal with those organisms.
Okay. Okay, right. So we'll discuss it further, right?
Next, can I invite Dr. Santosh Mahapatra? He's the Chief Medical Officer at JPN Rotary Eye Hospital, Cuttack, and he's also the Secretary at Odisha Ophthalmic Society. And he's a prolific vitreoretina surgeon there. Dr. Santosh?
Good morning, everyone. I'd like to thank Scientific Committee AIOS, Dr. Sabyasachi Patnaik and Dr. Pranam to give me the opportunity to talk here. Just as discussed, it's a case-based discussion. So I'd like to discuss the situation, gross diminution of vision in a relatively quiet eye around day 10 to 15 in a post-operative case. So the first case here is a 72-year-old male who has undergone cataract surgery in the right eye 13 days back, presented with visual acuity of counting finger 2 meter in the right eye with mild circumciliary congestion, SC reaction, but gross vitritis. You can see the anterior segment picture is relatively quiet, but the fundus is view is very hazy. You could not appreciate the disc or the blood vessels. So the case was diagnosed as any other case of acute onset post-operative endophthalmitis and advised for vitreous tap and VCD. So post 7 days he was reviewed again, but the vision was not improving. It deteriorated to hand movement. IOP was maintained but there is decrease in AC reaction because of we have started steroids, but the vitritis is persisting and the vision has decreased. So is it a fungus? We thought, and it was evident on the next visit with you can see this is the first 7 days picture, and this one is after again another 1 week, where you can see typical fungal balls on the fundus just near the posterior pole as well as in the periphery. So he has undertaken for surgery. You can see the anterior segment is still looking white, but the vitreous was seeded with multiple snowball opacities around the posterior pole, which is extending to the periphery. As Dr. Deepak was telling, a complete vitrectomy was done, but you can see the balls were not moving. So meticulous care is needed to take out each fungal ball which is stationed over the retina, and you should not leave any snowball because it acts as a nidus, and it is the source. So it's like a culture which is seated on the retina, and each ball can potentiate another course of infection if left. So it needs a meticulous care to go with a fluid needle, take out each fundus spot, because the retina you may injure if you go close with a vitrectomy, and fluid exchange is done, you can see the fundus is very clear. So when the vitreous staff was sent for culture, we KOH mount, we could see the fungal hyphae suggestive of aspergillus. It was on Sabarot's agar gave rise to fungal colonies. Another case, post-vitrectomy, is reported on day 15. This is the post-op picture. So we'll go to case 2, uneventful cataract surgery, phaco undergone, reported on day 18, again a relatively quiet anterior segment, but the fundus was not very clearly visible, only the vessels were appreciated. As discussed, he was again treated as a post-operative endophthalmitis with antibiotics, steroids, cycloplasics, but no improvement. Day 25, the AC now had a clear-cut pupillary membrane sitting over the IOL, and definitely we thought might be dealing with again a fungal endophthalmitis. Taken a BISCAN also correlated and taken up for surgery. So as I said, the lens is you can see there is a very clear-cut membrane over the lens, and we tried to save we succeeded in saving the IOL, and we removed both the anterior and posterior capsule and left the peripheral capsular rim so that the IOL remains stable, but at the same time all the needles of infection in front of the IOL as well as from behind is being cleared, and you can see the vitreous cavity it was looking innocuous, but on induction of PVD, yes, now you can see that there is a gross, yes, few fungal balls are seen and dense vitritis which need to be cleared completely. Near complete base excision need to be done repeatedly. We are stressing upon this point because if you leave any needles of infection, your treatment is not successful. So need to overlay cases with not missing a fungal endophthalmitis, and when we need to suspect the fungal endophthalmitis. You need to suspect fungal endophthalmitis when there is a relatively less edema, but you can see white yellow infiltrates following cataract surgery in the wound, and a hypopyon which is relatively solid, not moving with eye movement and has a convex border, and on vitreous you can see dense vitreous exudate with string of pulse, and creamy white circumscribed chorioretinal lesions can be seen sometimes like this. You can also have associated retinitis or retinochoroiditis, and need to give the proper history to rule out diabetes or other causes of immunosuppression and do a complete laboratory test. So paracentesis and vitreous biopsy is of paramount importance because you need to cleanse the diagnosis as a fungal origin. So you also need to sometimes do PCR or SGA agar, and the common positive organisms are Candida or Aspergillus. So early vitrectomy and complete vitrectomy is the key, along with intravitreal and systemic antifungal drugs. So my take-home message is postoperative fungal endophthalmitis is rare, but yet a vision-threatening ocular inflammation, lack of clinical suspicion, and empiric use of corticosteroid without proper antifungal coverage increases the risk of significant vision loss. Early diagnosis, early vitrectomy, and more than one time intravitreal antifungal injection and prompt effective oral antifungal therapy is crucial to manage this kind of cases. Thank you.
Thank you, Dr. Santosh. So, in how many cases did you put silicone oil in any of
In these two cases, it was not needed because they reported very early and operated in our hospital. So, as usual, we call each patient at 7 days for follow-up. So, they were not giving any pain or something, but on examination, we could see there is something wrong. The vision has decreased from the day of post of 1, and it was definitely giving a clue. So, in these two cases, IOL removal or silicone oil were not needed. But if you see a case where there is a lot of exudates, there is no clarity, and there is
there may be a
active retinal inflammation, definitely you can consider silicone oil.
Okay. Thank you.
Dr. Santosh, just one query that I have. These fungal and endophthalmitis, whether they are of mostly exogenous or endogenous origin?
Following surgery, it is exogenous.
Okay, right.
But we always need to rule out endogenous cause if there is a cause like uncontrolled diabetes or any other cause of immunosuppression, and the patient might have infection somewhere else, which might cause a endogenous endophthalmitis.
Like with patients of diabetes, patients who are immune suppressed.
One of the first patient was a uncontrolled diabetes.
Okay, thank you.
Thank you.
Next, may I invite Dr. Subhashi Patnaik, sir. He is the Chairman, Scientific Committee of AIOC and Senior Consultant and Additional Director, Health Services, Government of Odisha, for his presentation. Thank you.
So, good morning.
That's it.
So, good morning, everybody. I thank Dr. Pranab Ranjan sir for giving me this scope of presenting before you. What we are discussing today in this morning is endophthalmitis, post-operative endophthalmitis. The very purpose of all this discussion is prophylaxis of endophthalmitis actually, how to avoid this condition to happen. Now, if this happens, then what to do? So, what we have discussed today, that all precautions, preoperative sterilization procedure and others have to be taken very seriously in undertaking any before any intraoperative procedures in eye surgery. The second thing is installation of povidone iodine before the surgery and also a single drop after the surgery. So, this ensures 100% protection from endophthalmitis. But still, if it happens in spite of all this, then we have to promptly deal with the situation in order to save the sight of the patient. Now, at times what happens, we can see just a case of hypopyon also in post-operative period. So, we should not be panic in all situations. So, I am going to present two case scenarios. One is 53-year-old female, history of diabetes for 2 years, hypertensive, cataract surgery in the left eye undergone 2 years back, and presented with loss of vision in the right eye for the last 6 months as per her version, and he was advised for cataract surgery. So, this is the preoperative finding of that patient, counting finger 4-meter vision, IOP normal, patent LPI, then mature cataract, fundus, no view in the right eye. So, what we expect is there was an uneventful cataract surgery, as any ordinary day for any cataract surgeon. So, expectation was good vision, better than 6.9 in that eye, normal IOP, cornea clear, everything good. But what we see is this type of situation. In the first post-operative day, vision is 5/60, pressure slightly high, conjunctival congestion, limbus to limbus corneal edema, SK, hypopion, AC reaction, severe, fibrinoid exudate over the IOL, but no cells in the antrovitreous space. Fundus relatively quiet, though not very clearly visible. No vitritis and retina is on. So what to do? Now we can think of a situation of TAS in those situations. So what we did is hourly topical steroid, routine antibiotics, topical cycloplegics, oral steroid, pattern bandage, and anti-glaucoma medications were also advised. Now things improved within 7 days, visual acuity improved, and everything now appearing to be tending towards normal. And in day 15, we had a good vision, and the outcome is good. So it is not that in every situation we have to be panic in dealing those type of situations. So we have to assess properly and deal with that. So immediate post-op AC reactions within 24 hours with mild pain, watery discharge, no purulent discharge, relatively less conjunctival injection and lead involvement, limbus to limbus corneal edema, fibrinous exudates and hypopion with relatively lesser AC reactions, normal IOP, no vitreous reaction, all these lead to TAS. So, but this is to be differentiated from infective endophthalmitis, which usually appears little later. Pain always present, lead edema is possible, conjunctival congestion, there is always, there is patchy corneal edema, variable pupil size, variable IOP, and temporary suppression of inflammation to steroid medication.
अब किस नाम से टॉपिक
So TAS can be because of many factors like bacterial endotoxins, intraocular irrigating solutions with abnormal pH,
ऊपर आ जाइए ना
denuded ophthalmic surgical devices, visco, intraocular any medications, topical and ointments also, inadequate sterilization of surgical instruments and tubing, inadequate flushing of instruments between cases, preservatives and metallic precipitates. So, take-home message is not all AC reactions are endophthalmitis. Even a hypopion can be sterile, just as in TAS. Acute severe inflammatory reaction of antechamber within 12 to 48 hours of surgery. Corneal edema extending from limbus to limbus. Dilated and irregular pupil, normal or slightly increased IOP. Presence of hypopion and lack of bacterial and fungal growth all lead to the diagnosis of TAS. So, thank you very much.
Thank you, sir, for that presentation. So definitely, whenever there is a hypopion, we have to actually think whether it's an endophthalmitis or TAS. So the most important differentiating features which sir had just mentioned is like the duration. Probably immediately within 24 hours, if they present, it could be TAS. But one thing is that if there is any doubt whether it is TAS or endophthalmitis, I think it is always better to err on the side of endophthalmitis and give intravitreal injections if there is any doubt.
In that case, I think BISCAN will help. You have to do a BISCAN to see.
To rule out vitreous involvement.
Because TAS primarily is a anterior segment inflammation, whereas endophthalmitis is a posterior segment. And there are so many vitreoretina people here. Just
but despite that, sometimes there is a doubt. For example, patient that presents after 3 days with accelerated iritis. Okay, the vitreous may be clear. You give steroids. Okay, it recovers. And again, after few days or weeks, again if they develop, iritis. So these are the cases which are actually, creates a doubt in your mind whether it is, iritis or is it, going in for chronic fungal.
I think he has given a clue. If it is not improving within a week, definitely you can think in line of Endoph. But if it is improving within a week, I think it is more in favor of TAS.
Corneal infiltration also an important sign to exclude that. But still, we have to be very careful and think in mind that there can be endophthalmitis.
Yes.
We cannot rule out that, cannot be very much sure definitely that this is TAS and not endophthalmitis. So that has to be
very cautious, close monitoring.
Mind and close monitoring of the patient is very important to save the sight. Thank you, sir. Thank you very much.
I just wanted to ask them the role of ultrasonography in differentiating between TAS and endophthalmitis.
Yeah, it is of paramount importance, and you need to do it even if you suspect TAS. So you
yes,
audible.
Mic.
आवाज नहीं आ रहा. These mics are not working properly.
वहाँ पे.
It's work. Hello. Now it's work. Hello. Yes. So, as far the TAS and endophthalmitis is concerned, the classical teaching is usually in the initial 3 days. If there is it is usually uveitis, not endophthalmitis. Just wanted to ask the chair and regarding that.
I think 3 days is a long time. Acute bacterial endophthalmitis, the presenting will be after 2 days.
Okay.
Most of the time, if a patient comes after 2 days of cataract surgery saying I'm having pain or redness, the first thing which will alert me, it is a acute bacterial endophthalmitis.
And associated signs and symptoms. They are like
absolutely
edema, severe pain,
yeah,
conjunctival circumferential congestion, and
even if the symptoms are not so alarming, even if there is congestion after 2 days which was not there before, it will warn me like it may be an endophthalmitis. So 2 days is a very crucial time, which I would say, because be very cautious for 2 days, because acute bacterial endophthalmitis will present, the acute bacterial endophthalmitis presents within 2 days of cataract surgery.
Let's listen to the question first. What's your question, sir?
No, the question was, usually the classical teaching is that whenever there is inflammation in the post-op period, if it is presented within 3 days, it's usually because of uveitis, not endophthalmitis. It was very clear. And then thereafter, 8 to 9 days or within 1 week, it may be more of related to infections or like that.
Yes, that is correct, because after post-operative, during discharge, the patient was all right, vision is good, there was no complaint, and subsequently developed some problem like pain and other things. That goes in favor of endophthalmitis. As usually you see in the next post-op, fast post-op day, there is reaction.
No, what 7 days you are saying, it's a subacute endophthalmitis.
Okay.
Okay, so the organisms may be different. So 7 days is a very long time, and the classical acute fulminant, if you say, or acute bacterial endophthalmitis will present within 2 days.
Within 2 days.
Dr. Deepak, will you agree? What I have read in the literature, 3 to 5 days is the average for bacterial endophthalmitis, and within 24 hours is TAS.
Within 24 hours it is TAS, but beyond that, it should ring a bell that this could be acute bacterial.
Absolutely.
So 2 days is a
2 days.
2 days. Yes.
Okay.
Yeah, actually, you remember, Dr. Deepak, there is one case, and it presented 3 days, just after 3 days surgery, and it was a fulminant. We lead to the corneal infiltrates and everything.
Yeah.
But most of the time, it presents usually late to us.
I think, Ajit, this is a very good message. If it is within 24 hours, 1 day, it goes in favor of TAS, and if it is between 1-2 days and beyond, that goes more in favor of the bacterial and endophthalmitis.
And that too in TAS, the symptoms improve with treatment.
Yes.
And in bacterial and infective endophthalmitis, it will deteriorate.
Definitely. Thank you.
So, can I just ask, what should be the ideal post-operative review regime in these cases? So we cannot call them obviously on every day for post-operative review?
No, it should be called, they should be called every day.
No,
Ideal.
generally,
Yes,
post-operative cases, I'm asking. Not
No.
with, any case
If you
with
are if you are seeing a reaction like this, you should call the patient every day or keep him admitted to see.
No, because first day there could be TARS, second day there could be an acute endophthalmitis,
That's why you need to
fifth
see
day
every
also there could be an endophthalmitis. So what should be the usually how do you call these patients?
I mean, this, yeah. Should,
Yeah, so what is like first day you see, which is better, the immediate first day post-operatively or after 48 hours?
Definitely
The first review.
first day
First day
post-operative
they have to be
absolutely is.
seen.
First day is better.
First
Okay.
day, first week.
Yes, first day and first week, and in between, if they have any complaints, they should come, because first day it should be seen to see if there is any inflammation, what is the immediate post-operative status of the patient.
Yeah.
So one day after the surgery, patient has to be seen.
Oh, okay, okay. Because sometimes when we do it on Saturday, we call them on Monday.
Madam, practically what I have been following for the last 15 years is that I see all patients after 6 hours and then next day.
Oh, okay, okay. Thank you, sir.
Message is you have to see the
You are
patient.
telling after 2 days it may be a postoperative endophthalmitis. Then whether we can continue with steroids or stop steroids, and after it is tap only we can.
Yes, steroids, topical steroids, it should be given to control the inflammation, but the dose has to be reduced. If you're giving hourly, it should be at least four times per day. But it should not be stopped because it's going to control some amount of inflammation also. The only thing is oral steroid should not be given until and unless a vitrectomy has been done. You understand? Yeah.
Can I ask one more question? So when you see these fungal postoperative cases, where do you think these infections are arising from?
Most.
Is it a sterilization protocol that's to blame, or is it the
Just we
patient?
discussed that it can be exogenous or endogenous. If it is, if the
Yeah,
patient is-
exogenous. We are talking about the exogenous. Because post-operative, no? So mostly it will be exogenous only.
it can be through the wound most of the time.
It can be from the wound, it can be from the saline,
Yeah, I'm
the
asking.
source.
Saline.
It can be from the saline or from the viscoelastic also.
Viscoelastic is also possible?
Yes, yes.
Anywhere fungus can be there. Okay, I think
So next, can I invite Dr. Shivani Sinha? She's also a prolific vitreoretina surgeon from Patna, and she did her MS from King George Medical College, Lucknow, and she did a fellowship in vitreoretina from Narayan Netralaya, Bangalore. And she has many publications in her name and has co-authored 6 book chapters also. So Dr. Shivani.
Good morning, everyone. I'll be presenting on traumatic endophthalmitis. At the outset, I would like to thank Dr. Pranav Ranjan sir and AIOC Kochi for giving me a chance here to present. So, development of endophthalmitis in a traumatic eye unfavorably affects the clinical course and results. And the microbiology and the clinical risk factors are different from the other forms of endophthalmitis. So, I will begin with the 2 cases. So this is a case which underwent corneal perforation, penetrating injury repair elsewhere, and was referred to us. And we can see a lot of exudate in the pupillary area and with no view. Ultrasound was done, and we suspected a retinal detachment in this case. We went through the anterior approach, cleared the exudates from the pupillary area, went ahead with an lancectomy, and then so there are thick exudates in this pupillary area. Finally, we did remove it, and then we went through the pars plana approach because it was difficult for the placement of cannulas there. So the vitrectomy is being done, and we see the retinal detachment here. So there was a break, and the break was localized, and the vitrectomy was completed with the installation of the silicone oil. This is the second case wherein we can see there is a corneal penetrating injury, and we had to repair it first. Again, we had to clear the pupillary area because there were exudates in the pupillary area, and we can see dense exudates in the posterior segment also. B scan was done previous to the surgery, and we had suspected a intraocular foreign body in this patient. And fortunately, we were able to localize that IOFB during the surgery. We removed it through the by the help of intraocular forceps, and then removed it by the handshake technique, and then again completed the surgery by instilling the silicone oil. So these were very two straight cases of traumatic endophthalmitis where we went ahead with vitrectomy as the first choice of surgery. So the post-traumatic endophthalmitis comprises approximately 25 to 30%, and the incidence is 10 times more than the post-surgical endophthalmitis. So it is more common with the open globe injury, and the rate changes exponentially with the presence of an IOFB. So it is more with the when the IOFB is soil contaminated and non-metallic IOFB, and we have to suspect post-traumatic endophthalmitis by our clinical examination, and we need to distinguish it from the traumatic acute inflammatory reaction from a real endoph. So the development of hypopyon, increasing pain, accompanying corneal infiltrates, retinitis, periphlebitis, and vitritis, they all are alarming signs for the developing endophthalmitis. So we have to consider the diagnosis of endophthalmitis in all cases with a history of trauma. We have to examine meticulously for the presence of an IOFB in these cases. So coming to the risk factors, any retained IOFB, lens rupture, delayed timing for primary repair, large wound size and location of the wound also determines the incidence of endophthalmitis, and placement of IOL during the primary repair also all are risk factors for the development of post-traumatic endophthalmitis. So there is no safe delay period in surgery, and 91% of the eyes, they develop post-traumatic endophthalmitis because there is a delay of the primary repair. So we have to take samples for cultures and stain from the wound anterior chamber or vitreous, and we have to look for IOFBs by radiology like X-ray, CT scan, and ultrasound. So we have to be especially careful when the IOFB is of glass or wood because they are not easy to image. So the incidence of streptococci and gram-negative bacilli, they are more in traumatic cases, and the prognosis of these are worse when compared to the others. When Pseudomonas and anaerobic Clostridium, they are implicated, especially in soil-contaminated cases, and they are fulminant also. So the incidence of post-traumatic fungal endoph is approximately 4 to 14%, and when the cause is aspergillus, it usually results in panophthalmitis. So any treatment, it involves open globe injury because we have to do a primary closure as soon as possible within 24 hours. So the management involves use of intravitreal, intravenous, topical, and subcunj antibiotics, role of steroids, and role of vitrectomy. So we have to go with the empirical intravitreal, proven intravitreal antibiotics with intravitreal vancomycin and ceftazidime. And in cases where we are suspecting bacillus, we have to go in for intravitreal vancomycin with addition of amikacin. So there is a role of prophylactic intravitreal antibiotics also when 2 or more risk factors are involved, like when there's a delay of repair more than 24 hours, a dirty wound, or a lens capsule breach. Although it is not proven, but systemic antibiotics, they are usually applied in patients with open globe injury, and clindamycin is added when there is suspicion of bacillus. Topical antibiotics, we can use it either in the form of fortified topical antibiotics or topical fluoroquinolones because the penetration is much higher when compared to the other groups, and it is biologically more active against the staph epidermidis in comparison to the catafloxacin. So coming to the steroids, all the aspects of corticosteroid use are debated regarding timings, dosing, and the route of administration. So steroids are needed to combat both the inflammation and the infection part of the endoph. So a potential disadvantage can be because of the possibility of suppressing the infection control, and it becomes very prominent if the endoph is predominantly of fungal origin, and also when the microorganisms are resistant to the empirical antibiotics. So vitrectomy does remove a sizable portion of the nidus. It clears the media by removing the vitreous membranes, and it eliminates the vitreous scaffolding, which may be responsible for retinal detachment in future. So PPV combined with intravitreal antibiotics is a more effective strategy for sterilizing the vitreous cavity. So When is prompt vitrectomy recommended? It is recommended in case of an IOFB, and also if the media clarity is such that we have got no view of the optic nerve head, vitrectomy is also indicated. So the extent of vitrectomy is controversial, and we use silicone oil tamponade when we have a concurrent RD or when the risk of occult retinal tears is high, and also it has an antibiotic role in prevention of developing further infection. So when it comes to the IOFB, we have to have a prompt surgical management in these cases. If there is a delay by for any reason, we have to go in for a vitreous biopsy and intravitreal antibiotics. So the challenges are many, and because of the clarity of the media, lens injury, and vitreous hemorrhage, they all preclude the view of the retina. The PPE complications are far more higher when compared to the conservative cases, and presence of foreign media, they all make the view view miserable. RD, the chances of RD, the chances of phthisis is more in these cases. The final visual acuity is generally lower in the post-traumatic endophthalmitis cases, and the development of phthisis and enucleation rates are also higher. So the timely diagnosis and prompt management can help salvage the eyes as well as vision. Thank you.
Thank you, Shivani, for that wonderful presentation. So basically, when there is traumatic endophthalmitis, the organisms implicated, like, do you think it's mostly a polymicrobial infection?
So it can be, because when often we get children, the pediatric patient, when they are needle stick injuries, where we get a combination of pseudomonas or bacillus along with the normal strep and stuff. So we have to have a culture and then go in by the sensitivity to the particular antibiotics.
Yeah. And do you think silicone oil should be, injected in all cases of traumatic endophthalmitis, keeping in mind, the poor prognosis which is there later on? So do you think, like, if we put silicone oil, that would help?
Sir, if we have a very permanent kind of picture, and if we are concurrent RD, or if we have we are suspecting RD in future,
if there is no RD, I'm saying, even if there is no
Sir, if there is permanent, then we can proceed with the installation of the silicone oil. But if we are able to clear the whole, if we are able, that is a rare thing to happen, that we clear the vitreous of all the exudates and of all the microorganisms. So in cases of permanent only, I think silicone oil is needed.
Okay, thank you. Any questions?
Yeah, I have a question.
Yeah.
Fantastic talk, Dr. Shivani. In terms of pediatric endophthalmitis versus adult traumatic endophthalmitis, do you think the organisms are different, the prognosis is different, the way you will approach the patient will be different? How would you look differently for a pediatric traumatic endoph versus an adult onset adult traumatic endoph?
So the mode of injury, usually in the pediatric, we get needle stick injuries or a wooden injury because they are playing with the stick and arrow and bow and arrow things. But whereas in adults, we usually have occupational, we have a hammer chisel kind of thing. So there the involved IOB is usually metallic, which is sterile, more towards the sterile because of the heat thing. But in children, it's not like that, and the microbial composition also differs because of the involvement of the soil contaminated IOB, and they become more of pseudomonas and bacillus, which are more permanent when compared to the other traumatic endophthalmitis. In a way of approach also, it's very difficult because we cannot take children for repeated vitrectomies under GA. GA becomes a thing particularly for children, and in adults we can always take under topical. So step by local, sir. So we can take under local anesthesia. So step, if we are planning to do a core vitrectomy kind of thing, followed by a more vit later on, that is not possible in cases of children. Also, when we are going onto the visual rehabilitation, it is more difficult in cases with children, because when we do lensectomy and then we are planning for a later secondary IOL placement, then it becomes a challenge, because when the children are less than 5 years or 2 years, then it becomes a challenge. While in adults, we can always go for a secondary IOL placement and a better visual rehabilitation in those cases.
So what we have seen is that we published a recent paper on pediatric traumatic endophthalmitis, and actually the duration of presentation of a child to the clinic is much longer because the child actually fears to tell that he has had an injury. So the patient, when he comes to you, or the child when he comes to you, comes with a more worse prognosis, more exudation, more fulminant features than a patient who's in the adult age group who comes in with an immediate following an immediate injury. So that's an important thing. And what do you think about the membrane formations following vitrectomy in pediatric versus traumatic cases?
In pediatric, it is more when compared to the adults because inducing a PVD is more challenging in cases of pediatric cases rather than in adults. So we are not able to induce PVD in pediatric cases. That leads to more formation of membranes in them.
Yeah, thank you so much. Again, nice talk.
So with this, yeah, we conclude this session here. So can we have all the speakers on the dais for a photograph?